Normal fasting glucose. In 1889, German physicians Joseph von Mehring and Oskar Minkowski removed the pancreas from a dog and observed that the animal rapidly developed diabetes, establishing the first direct link between the pancreas and blood sugar regulation. The American Diabetes Association defines normal fasting glucose as below 100 milligrams per deciliter, measured after at least 8 hours without food or caloric beverages. What most patients don't know is that a single fasting glucose reading captures only one snapshot. Blood sugar fluctuates constantly throughout the day, meaning a normal fasting number doesn't rule out dangerous postprandial spikes that never appear in routine blood work. The blood draw happens in the morning before breakfast, and the number that comes back feels deceptively simple for a system that involves the liver, pancreas, muscles, and brain simultaneously negotiating fuel. Prediabetes. The term entered official medical classification in 2003 when the American Diabetes Association lowered the impaired fasting glucose threshold from 110 to 100 milligrams per deciliter, instantly reclassifying millions of Americans as metabolically at risk. Prediabetes is defined by fasting glucose between 100 and 125 milligrams per deciliter, or an A1C between 5.7 and 6.4%. What catches patients off guard is that prediabetes produces no symptoms whatsoever. No fatigue, no thirst, no warning signal, which means most of the estimated 96 million Americans living with it have never been told. The contradiction that unsettles clinicians most is that arterial and nerve damage associated with diabetes begins accumulating during the pre-diabetic stage, long before the diagnostic threshold is crossed. A patient receiving a pre-diabetes result often leaves the office feeling fine, unaware that the metabolic damage has already quietly started. Type 2 diabetes. Ancient Egyptian physicians described a condition of excessive urination and wasting in the Ebers Papyrus around 1550 BCE, making diabetes one of the oldest documented diseases in human history. Type 2 diabetes is diagnosed when fasting glucose reaches 126 milligrams per deciliter or higher on 2 separate occasions, or when a random glucose reading exceeds 200 milligrams per deciliter alongside classic symptoms. Despite being called a blood sugar disease, type 2 diabetes is fundamentally a disease of insulin resistance. The pancreas often produces normal or even elevated insulin, but the cells stop responding to it, forcing glucose to accumulate in the bloodstream. What surprises most patients is that the diagnosis line of 126 milligrams per deciliter is a clinical consensus threshold, not a biological cliff. The metabolic dysfunction driving it began years or decades earlier. The moment a doctor writes the diagnosis feels abrupt, but the body has been signaling the problem far longer than any single blood test reveals. Type 1 diabetes. In 1921, Canadian researchers Frederick Banting and Charles Best isolated insulin from dog pancreatic tissue at the University of Toronto, transforming type 1 diabetes from a death sentence into a manageable condition within months. Type 1 is characterized by fasting glucose above 126 milligrams per deciliter, but unlike type 2, it results from autoimmune destruction of the pancreatic beta cells that produce insulin, meaning the body generates none at all. What most patients and many clinicians don't immediately recognize is that type 1 can develop at any age. It's not exclusively a childhood disease, and misdiagnosis as type 2 in adults is common enough to have its own clinical designation, LADA, or latent autoimmune diabetes, in adults. The defining test is not glucose itself, but C-peptide, which measures residual insulin production and reveals whether the pancreas has been silenced entirely. Without insulin injections, type 1 glucose can climb above 600 milligrams per deciliter, a level at which the blood thickens and the body begins dissolving its own fat and muscle for fuel. Hypoglycemia. In 1848, French physiologist Claude Bernard first demonstrated that the liver stores and releases glucose into the bloodstream, establishing the foundational mechanism behind blood sugar drops that science would spend the next century learning to measure and treat. Clinically, hypoglycemia is defined as blood glucose below 70 milligrams per deciliter, with severe hyperglycemia occurring below 54, at which point cognitive function begins to deteriorate measurably. What surprises most people is that hyperglycemia is not exclusive to diabetics. Reactive hypoglycemia, fasting hypoglycemia, and medication-induced drops occur regularly in non-diabetic individuals who never suspect low blood sugar as the cause of their symptoms. The brain consumes roughly 20% of the body's glucose despite representing only 2% of its mass, which is why the first symptoms are neurological: confusion, irritability, and difficulty concentrating, rather than physical. Below 40 milligrams per deciliter, the hands shake with a tremor that feels borrowed from someone else's body. Hyperglycemia. The word derives from the Greek hyper meaning over, glykes meaning sweet, and hymer meaning blood, a combination first used in medical literature in the late 19th century as chemical analysis of blood became possible. Hyperglycemia is defined as fasting blood glucose above 130 milligrams per deciliter or postprandial glucose exceeding 180 milligrams per deciliter 2 hours after eating. What most patients misunderstand is that acute hyperglycemia and chronic hyperglycemia cause fundamentally different types of damage. A single spike after a meal is handled by insulin within hours, while sustained elevation above 140 milligrams per deciliter begins glycating proteins in blood vessel walls in a process that is largely irreversible. The paradox that confuses newly diagnosed patients is that mild hyperglycemia produces almost no immediate sensation, yet it is silently coating nerve endings, lens proteins, and arterial walls with glucose molecules that accumulate over years. A blood glucose of 180 milligrams per deciliter feels indistinguishable from 90 milligrams per deciliter until the damage has already compounded. Dawn phenomenon. In 1981, endocrinologist F. M. Schmidt first described and named the effect in diabetes care after observing unexplained morning glucose elevations in diabetic patients who had maintained stable overnight levels. Between approximately 4 and 8 a.m., the body releases cortisol, growth hormone, and glucagon in preparation for waking, signaling the liver to release stored glucose into the bloodstream. Optimal fasting glucose remains below 100 milligrams per deciliter, but in individuals with impaired insulin response, these hormonal surges push morning readings 20 to 40 milligrams per deciliter above their midnight baseline without any food consumed. What catches patients off guard is that the dawn phenomenon makes fasting glucose an unreliable standalone marker. Two people with identical overnight diets can wake up with readings 50 milligrams per deciliter apart based purely on hormonal timing. Continuous glucose monitors made this effect visible for the first time to non-diabetic patients, revealing a pre-dawn glucose climb that standard morning blood work had always captured mid-rise, never at baseline. Reactive hypoglycemia. The condition was formally characterized in the 1920s following the widespread clinical use of insulin, when physicians began observing blood sugar crashes in non-diabetic patients several hours after eating. It occurs when blood glucose drops below 70 milligrams per deciliter within 2 to 4 hours of a meal, triggered by an exaggerated insulin response to carbohydrate intake that overshoots the actual glucose load. Most patients and many physicians misidentify reactive hypoglycemia as anxiety, fatigue, or panic attacks because the symptoms, rapid heartbeat, sweating, mental fog, are neurological and indistinguishable from stress responses. What makes it clinically elusive is that standard fasting glucose tests miss it entirely. The drop only appears during a mixed meal tolerance test or with continuous glucose monitoring after eating. The blood sugar reading during an episode sits at 58 or 62 milligrams per deciliter, while the patient feels the floor dropping out from under them, not knowing that the cause was a meal eaten 3 hours earlier.